Welcome to your annual education on nutrition and hydration assistance. Eating a meal or drinking something that you enjoy can influence quality of life and social well-being. Why do we eat and drink? To maintain health, to satisfy hunger or thirst, for pleasure, for social interaction, to celebrate, and many more reasons. Benefits of eating well and staying hydrated are helps fight infections, avoid skin breakdown, build strength for activities and movement, and improve mental alertness. Mealtime is more than just satisfying hunger. It's also for sensory pleasure, comfort, control, security, companionship, satisfaction and accomplishment, as well as dignity, happiness, sharing, acceptance, laughter, and affection. As we age, our bodies go through changes that can impact our ability to select, consume, and enjoy food. Once you understand the influence of these changes have, you can offer the support needed to help reduce the impact of these changes and encourage the resident to eat. Factors that can lead to residents' ability to eat or drink independently include aging, decreased physical activity, decreased sensation of thirst, physical disability like arthritis or stroke, medical diagnosis or conditions like Parkinson's disease or MS, changes in swallowing mechanism, pain resulting from poorly fitting dentures, decayed or broken teeth, changes to the texture of food and consistency of liquids due to recommendations from a feeding and swallowing assessment, effects of medication, medication interactions, and medication side effects, a change in eating habits, food likes and dislikes, cultural or religious restrictions, dementia or other cognitive impairments, and mental illness. Chewing and swallowing is very complicated with many steps. First, we have to get the food into our mouth. Once it is in our mouth, we chew and use our lips, tongue, and cheek muscles to control where the food goes. Saliva is added and we form it into a lump that is called the bolus. At this point, we are breathing through our nose. This is called the oral stage of the swallow. Once the chewed food is in a bolus, it is moved to the back of the mouth by using our tongue to push the food up against the hard palate. When the food gets to the back of the mouth, we seal the entrance to the nose by closing the soft palate, and at the same time, we stop breathing in. The food will then be pushed into our throat, also known as the pharynx. The epiglottis will move down to help seal the airway or the trachea, thereby allowing the food to move into the esophagus and down to the stomach. Then the epiglottis moves up. The soft palate relaxes and we breathe again. Normally, this takes place in less than a second. When muscles of the face, lips, and tongue are weak and not functioning, our sensation around the mouth is reduced. A person could have trouble chewing or controlling where the food goes in their mouth. Food may get stuck in the cheeks or inside the mouth between the tongue and the teeth. This is called pocketing. Food or fluid may also spill out in their mouth. Residents might not be able to control the food or fluid in their mouth, resulting in it moving into their throat before they are ready to swallow. This could result in food or fluid entering the airway, causing the resident to cough or choke and possibly develop a chest infection or pneumonia. Residents are unique and they will have a distinct care plan tailored to their needs and wishes. Here is an example of a resident care plan. The resident needs a set-up assistance. She is blind and staffed to identify location of food on plate. She has a low potassium diet. This resident is eating independently, drinks regular fluid, and food consistency is regular cut up. She eats at the feeder's table and uses a blue plate. Other details you must be aware of: residents' food allergies and intolerances, food likes and dislikes, diet type including texture modified and liquid consistency modification, level of feeding assistance, whether it's independent setup, queuing, or dependent, residents' use of adaptive eating or feeding devices like rim plates, nosy cups, adaptive cutleries, etc. Any sensory limitation, and if the resident requires glasses, hearing aids, or needs certain cues or instruction to feed themselves. If the resident wears denture, ensure they are used. Any high-risk feeding or eating-related behaviors like impulsivity, attempting to eat non-edible items such as napkins, taking very large mouthfuls, eating too quickly, etc. Manage risk agreements. Some residents may choose to live at risk despite an identified choking risk. In this case, healthcare providers will negotiate with patients to minimize the risk as much as possible. In facility settings where residents eat together, interactions enhance the mealtime experience. Consider how residents are positioned in relation to one another. Residents are encouraged to be as independent as possible while eating, even if feeding assistance is being provided. Residents are recommended to be in an upright position during the meal and for at least 30 minutes after oral intake to prevent reflux. There are many steps before actually assisting the resident with eating and drinking. Wash your hands before and after assisting a resident with their meal. Encourage residents to wash their hands as well by offering hand sanitizer as soon as resident gets off the elevator. Talking with the resident you are assisting is important. It will increase their participation and it gives you cues if the resident is managing the food and the water properly. Doing this also helps make the meal more of a personal experience. Make sure the person you are assisting has everything they need for a successful dining experience. Do they have their glasses on? Are their teeth and their hearing aids in? It is also a good time to check if they have any adaptive utensils or cups that have been recommended to improve their independence. Encourage residents to eat independently if they can do so, as most residents have the ability and willingness to assist during the meal, holding their spoon and bringing the food in their mouth. Sometimes, resident needs a verbal cue or reminder to take another bite or a gentle touch or guiding hand to direct the utensils to their mouth. Positioning is extremely important to prevent choking and aspiration. Positioning the resident properly will promote engagement and allow the resident to focus on the meal. The resident should be sitting with buttocks and back against the back of the chair or wheelchair. Their feet should be supported by footrest or the floor. If resident is leaning to one side, reposition the resident. Staff should be seated on a chair and positioned as close to eye level as possible to be able to check for swallowing and respond to facial cues. Avoid standing while helping residents during the meal. This increases the chance of choking and decreases oral intake. Staff monitors intake rate and able to assist in controlling it. Positioning a resident on a Broda or tilt chair. Raise the back of the Broda or tilt chair to the highest position the resident can tolerate. Use pillows behind the neck to place the resident in a more upright with the head tilted slightly forward. The resident should be sitting up to 90 degrees with all limbs supported. Ensure the resident is upright for at least 30 minutes after the meal to reduce the risk of food getting into the resident's lungs. The resident may only be able to eat in bed due to a medical need, an inability to go to the dining room, or other needs or requests. In this case, positioning the resident upright as possible is critical. raise the head of the bed, and slightly raise the foot of the bed to prevent from slipping. Offering different food consistencies. There are 5 primary diet or food consistencies as per AHS guidelines. This is a typical lunch. For regular, no texture modification for soup, burger, salad, and pie. Easy to chew is very similar to regular, except it's an open-faced burger and less raw vegetable is allowed. In salads, lettuce must be shredded, tomatoes are cut up. Other raw vegetables are allowed, such as cucumbers, but must be peeled and cut up. Carrots must be finely shredded. Dysphagia soft is similar to easy to chew, but less raw vegetables. Other raw vegetables allowed would be coleslaw. All meat must be cut up. On a minced diet, soup is pureed. All the meat is ground. No raw vegetables. Crust on pies may be too dry, but simple cake is allowed. For pureed, everything is a homogeneous texture. Residents may also need their fluids to be modified by thickening. Thickening the fluids may make swallowing safer as it gives the resident more control and time to react as the movement of fluids is slowed down starting in the mouth. This may also reduce the risk of fluid moving through the pharynx and into the airway before the resident is aware of the need to swallow. Fluid consistencies are mildly thick or nectar, moderately thick or honey, extremely thick or pudding. Check the resident's care plan before offering any fluid. Please note Jell-O, milkshakes, and ice cream are considered thin fluids as they melt at body temperature inside the mouth, turning into a thin fluid. Here at Jubilee, we use the Simply Thick Easy Mix bottle and pump to thicken fluids. To effectively dispense Simply Thick Easy Mix, for each stroke, use the palm of your hand to evenly press down. Keep pressing until you reach the full length of the pump distance. It is important that you experience smooth distribution into the beverage. Apply pump strokes according to the chart. What is dysphagia? Dysphagia is a difficulty or discomfort in swallowing. It is not a disease, rather, it is a symptom. It occurs more often in elderly than other age groups. Signs and symptoms of dysphagia: drooling, food falling from mouth, holding or pocketing food in the mouth, gurgly sounding voice following eating, wet congested breathing, increased runny nose while eating or drinking, coughing or choking on food before, during, or after swallow, weak cough, complaints of food caught in the throat, it's stuck, or chest pains with swallowing, refusal to eat, possibly afraid of choking or pain from eating, recent weight loss along with coughing or choking during meals, frequent chest infections, and increase in body temperature shortly after meal. While helping residents to eat or drink during meals, you may encounter some situations where you will have to react quickly to help your resident. If the resident chokes on food or fluid, your resident may show these signs: weak or ineffective cough, high-pitched noise while breathing in, difficulty breathing, skin color changes from pink to purple, unable to speak, and a classic sign of choking, the resident may hold their neck with both hands. Recognize and respond in accordance with your training, job description, and organization process. Important feeding tips. Positioning. Resident is ideally centered in the seat, feet supported if necessary, sitting up as close to 90 degrees as possible. Sit when feeding and position yourself at eye level with the resident. Only feed the resident when they are awake and alert. Start with a drink, first to help moisten their lips, tongue, mouth, and throat, and provide fluids intermittently. Tell the resident what food items there are before starting or with each bite or sip. Be positive about the food that is provided and do not mix food items together. Describe in an appealing manner what the resident is eating. Maintain resident safety and dignity. Rather than scraping food off the spoon using residents' teeth or lips, wait for them to close their mouth and actively take food off spoon or fork. Use wet wipes to remove excess food after the resident is done eating. Ensure food items are swallowed before giving more food. You are an important part of the healthcare team and the one seeing firsthand how the resident is managing at mealtimes. Always ensure to tell your supervisor or your nurse if the resident is having any difficulties. If you notice that the resident is not eating, unable to maintain good eating position, has impaired swallowing abilities, is coughing during or after the meal, please inform the dietitian and or the OT. Thank you.